Well, it is my pleasure to introduce Dr. Allie Tracey, a postdoctoral fellow at the Institute working in my lab. And Allie comes to us with a PhD from Michigan State University in kinesiology. She's been working in the brain injury neuropsychology lab for the past year, submitting multiple papers and working on lots of projects, including the one that you'll hear more about today. So take it away, Allie.
Thank you, Amanda, and thank you all for being here this afternoon. As Amanda mentioned, my name is Allie, and today I will be presenting on daily life after traumatic brain injury, examining time allocation, social participation, and affect using ecological momentary assessment. And first, I just want to make sure without the mic, can everyone hear me okay at this level? Okay, perfect. Okay. So today's talk is supported by a generous gift from Nancy and Marc Shrier, and we are grateful for their support and belief in our mission. And this workshop you can receive CME credits for attending this talk today, so I'll leave this slide up for just a few seconds if anyone needs to access this code up here. And the planning committee members have no financial relationships to disclose, nor do I have any financial relationships to disclose. So the primary objectives of the talk today will be to, 1, describe current patterns of social and community activity, as well as affective states, both positive and negative, among individuals with moderate to severe traumatic brain injury, or TBI. Explain how community activities and social interactions influence affective states in daily life among individuals with moderate to severe TBI, and discuss potential modifiable contextual factors such as activity type, location, and social context associated with emotional well-being post-injury, and explore how these insights can inform future interventions to improve quality of life. So to start with a little bit of background on moderate to severe traumatic brain injury, TBI is a leading cause of death and long-term disability in the United States, and each year approximately 90,000 individuals are left with a long-term disability resulting from a moderate or severe TBI. And recovery from moderate to severe TBI is often prolonged and highly variable, and many individuals experience a broad range of long-term consequences that can present as cognitive, physical, or emotional and behavioral. And these long-term consequences can affect daily life functioning, social participation, and emotional well-being. So individuals frequently experience diminished productive activity, strained family and social relationships, and reduced community activity. And declines in social participation relative to pre-injury levels are often reported, and individuals with TBI express a desire for more opportunities to engage in social and recreational activities. Additionally, passive activities such as watching TV often replace more active and interactive pursuits. There are also several implications for physical and emotional health following moderate to severe TBI. Weight gain is common post-injury, increasing risk for chronic conditions such as diabetes, and depression is also common and is linked to reduced participation in social and community roles. And activity contributes to emotional dysfunction and vice versa, highlighting the importance of interventions aimed at helping individuals with TBI resume previously enjoyable and meaningful activities or identify suitable alternatives to enhance their quality of life and mitigate adverse health outcomes. So one method that can assist in identifying the information needed to guide targeted interventions is ecological momentary assessment, or EMA. So EMA is a set of methodologies which allow subjects to report their experiences and perceptions in real time, in real-world settings, over time, and across contexts repeatedly. So the data is ecological in the sense that it's collected in real-world environments. What we mean by momentary is that it's focused on how the subject is feeling at any given time. And the assessments are based on clinical features of interest and involve several repeated measures. So EMA can span a variety of methodologies, and historically it's included the use of pen and paper diaries, but recently it's expanded to the use of technology to include text messages or smartphone apps and notifications to prompt participants to report on their experiences multiple times a day. So EMA is a promising, innovative tool for assessing real-time activity patterns, social interactions, and emotional states in individuals with TBI. It can capture the dynamic interplay of contextual factors in daily life that typical retrospective measures may not be able to capture. It can also capture real-time fluctuations in emotional states. It can preserve ecological validity, reduce recall bias, capture within day and between day variability, as well as capture within person and between person variability over time. So therefore, leveraging EMA to elucidate the interplay among activity patterns, social participation, and emotional experiences in individuals with moderate to severe TBI may inform the development of targeted interventions to improve functioning, community engagement, and emotional well-being in this population. So to address this, I'll be sharing the results of 3 separate analyses that are focused on the same line of inquiry. So the first 2 studies that I'm going to introduce are focused on data that was drawn from a previous randomized control trial that compared 2 treatments for anxiety and or depression following TBI. And then the third analysis is going to present preliminary data from an ongoing study that we're currently working on in the lab that was designed to address the limitations and gaps that were identified from the previous 2 studies. So we're going to start with the first study, which is real-time measurement of daily participation in adults with TBI using EMA. As I mentioned, that we leveraged data from a larger scale RCT that included an 8-week EMA period as part of a behavioral activation therapy treatment arm, and the primary objective of this analysis was to examine the associations between EMA-derived indicators of real-time participation and validated retrospective measures of participation and life satisfaction in order to identify areas of convergence and divergence between these approaches and to assess the added value of EMA for capturing real-world participation after TBI. So here we have the inclusion and exclusion criteria for this study. Based on enrollment for the study arm, which included the EMA and response rates that were over 33% to the EMA surveys, we included 28 individuals with moderate to severe TBI that was sustained at least 6 months prior to the analysis. Participants were all over 18 years old. They must have been able to demonstrate independence in basic home activities and ability to travel independently in the community. They must have demonstrated English fluency and ability to use an iPhone or an Android smartphone. The assessments used in this study arm and implemented in the analysis included the participation assessment with recombined tools objective, or the Part O, which includes 3 subscales: productivity, social relationships, and out and about, where higher scores on this inventory indicate greater participation. Participants also completed the satisfaction with life scale, which includes 5 items rated on a 1 to 7 Likert scale, where higher scores indicate greater life satisfaction. And then using the EMA notifications, participants completed an activity assessment, which I'll discuss on the next slide. So here we have the full EMA activity assessment that participants completed. So participants were asked questions every day, 5 times a day. What have you been doing over the past hour or so? How enjoyable was this activity? Did this activity give you a sense of accomplishment? Who are you primarily doing this activity with, and where are you? So for this analysis, only the first 4 weeks of data from the 8-week EMA study arm were used to correspond with the retrospective measures and minimize the impact of declining EMA adherence after the 4-week mark. So after the first 4 weeks of enrollment, we did see a decline in participation in the EMA studies, in the EMA surveys. And at T1, participants completed an in-person assessment that included the Part O and Satisfaction with Life scale. Then they were enrolled in the EMA platform that was downloaded onto their cell phone, and they completed the EMA surveys 5 times a day for the 4 weeks. And then at the end of the 4 weeks, they completed their T2 assessment, which again included the Satisfaction with Life scale and the Part O. So for our data analysis for this study, descriptive statistics were reported for the Part O and Satisfaction with Life scale at each time point. And then 4 EMA-derived proportion variables were used to quantify participation. So this was the proportion of time that participants spent at home, alone, engaged in productive activities, and engaged in social activities. And each of these variables was calculated as the number of endorsed prompts divided by the total responses over the 4-week period. And then we used linear mixed effects models, or LMMs, to examine whether EMA reported time was associated with change in Part O and Satisfaction with Life scores from T1 to T2. So here we have our participant characteristics for this specific analysis. The mean age of our sample was about 45 years old. The sample was primarily male, and the mean time to presentation after injury was about 6 years. So because of some scheduling conflicts and some of the T2 visits were scheduled slightly before or after the 4-week marker, however, the average time between T1 and T2 was still about 28.5 days, so still within that 4-week range. And we did observe favorable EMA engagement, with average response rates being 79%, and most participants responded to over 70% of the daily EMA prompts. Here we have some of the descriptive statistics for our traditional retrospective measures of participation, and again, that was the Satisfaction with Life scale and the Part O. And for the Part O, we have the breakdown for the summary score, productivity, social, and out and about subscales. And paired samples t-test determined that there were no significant differences between between the T1 and T2 outcome measures. And on the next few slides, I'll show a breakdown of the proportion of time that participants spent engaged in each of the EMA-derived measures of participation. So during the 4-week EMA period, participants spent between 0 to 76% of their time at home, between 0 to 95% of their time alone, between 0 to 79% of their time doing productive activities, and between 0 to 52% of their time engaged in social activities. So if you attended Amanda's talk a couple of months ago, you'll know that I love making a heat plot to demonstrate EMA data because I think it's a valuable tool to understand how outcomes may change on a day-to-day basis, as well as with in-person and between-person variability. So these heat plots were created to demonstrate how each EMA-derived participation variable illustrated the proportion of daily prompts in which participants endorsed a given activity across the 4-week EMA period. So on the x-axis, you're going to see each day of the EMA period, and then on the y-axis, each line represents each individual participant. Each box represents the proportion of time that participants spent engaged in a given activity across all 5 observations in that day. So these visualizations highlight with in-person variability, showing how the proportion of endorsed prompts fluctuates from day to day for each participant. So the degree of within-person variability differed across participants. Some consistently reported 0% endorsement for certain activities or context, and you can see that with the lighter colors. So some participants have lighter colored bands, which are gray or lighter yellow, so those are less time spent engaged in a certain activity, whereas others showed substantial variability, so you can see that as across the band the colors change drastically. And then other proportions, so that's how those proportions range from 0 to 100% over the study period. So here we have our LMM results. So we can see that EMA reported time engaged in productive activities was positively associated with Part O summary, productivity, and social scores. EMA reported time spent alone was negatively associated with Part O summary scores, and EMA reported time spent at home was negatively associated with Part O productivity scores. So what these findings from this analysis tell us are that participants with moderate to severe TBI spent a substantial proportion of their time at home and alone. And this does align with current research, as prior work has demonstrated a link between lower levels of societal participation and social isolation, which is a well-established risk factor for poor mental health, physical health, and social well-being, and for adverse long-term outcomes following TBI. We also found that EMA-derived measures captured meaningful between-person variability and demonstrated associations with traditional retrospective self-report measures of participation, and many of the associations aligned with expectations, such that positive relationships between EMA reported time engaged in productive activities and Part O productivity subscale scores were observed. And finally, the EMA-derived measures revealed substantial within-person variability not captured by the traditional retrospective self-report measures. And we saw that on our heat plots, as some individuals exhibited daily participation levels that spanned from 0 to 100% across the entire study period. So based on these findings, we're left with the question, why does capturing this within-person variability matter? So if we can measure how a person's experiences change on a day-to-day basis, we can study whether those changes are related to other important clinical factors, such as mood or affect, which leads us to our next analysis, EMA of affect in context after TBI. So again, this analysis included data leveraged from the same RCT as the previous analysis, and the primary objective was to examine the temporal patterns of positive and negative affect, as well as boredom, enjoyment, and perceived accomplishment as a function of activity, location, and social context. So the inclusion and exclusion criteria were the same as the previous analysis, so I won't go through that again. But for this analysis, we included the 2 weeks of EMA data that participants provided prior to making changes to their activities resulting from their behavioral activation therapy, which may have influenced their mood or activity reporting. So for this analysis, we only included 2 weeks of EMA data. And in addition to the activity assessment, participants complete the activity assessment via the EMA. Participants also completed the PANIS short form, which I'll talk about on the next few slides, and an additional adjective board when they were filling out their EMA surveys, the 5 times a day throughout the study period. So just to refresh, these are the activity-related questions that participants completed during the EMA period, and these questions included, what are you doing, who are you with, was this activity enjoyable, did you feel a sense of accomplishment? And this is the PANIS short form, or the positive and negative affect schedule. So these are additional symptoms that participants were reporting when filling out their EMA surveys on their phone every day throughout the study period. This inventory includes 20 questions total, 10 questions that are focused on positive affect, 10 questions that are focused on negative affect. All questions are rated on a 1 to 5 Likert scale, with higher scores indicating higher affect. And then, as I mentioned, an additional adjective was added to the end of this list board, and that was at the recommendation of consultants with TBI who reviewed the assessment protocol and felt that that was a necessary question to ask. So for our data analysis, we used, again, LMMs to examine the effects of contextual variables, including location, social context, and activity, on positive affect, negative affect, boredom, accomplishment, and enjoyment. So here we have the participant characteristics from this analysis, and based on the number of participants who provided sufficient data with greater than 33% response rates to the EMA surveys, we included 23 participants in this analysis. The mean age was about 48 years old. Most of the sample were men, and the median time post-injury was about 6 years. And again, we observed favorable engagements with the EMA surveys with a mean response rate of about 65%. For our LMM results, we found that time significantly predicted boredom as boredom increased over time, so increased over the study period. Levels of positive affect were significantly higher outside of the home while working and while doing chores, and were significantly lower when alone. Levels of negative affect were significantly lower while watching TV, but higher while doing chores and socializing. Enjoyment was significantly lower while alone and doing chores. And accomplishment was significantly higher while working and significantly lower while watching TV. So what these findings tell us are that, one, they're consistent with prior research suggesting that people with moderate to severe TBI spend much of their time at home and alone. And we also observed high rates of TV watching and low rates of exercise and outdoor activity in this study. And after TBI, many may experience a barrier to a physically active lifestyle, which may be associated with poorer health, function, and mood. We also observed higher levels of positive affect that were associated with productive activities such as working and chores. And we observed higher levels of negative affect that were associated with socializing, which may reflect anxiety or frustration experienced while navigating social situations. And this is also consistent with existing research, as many individuals with moderate to severe TBI experience difficulty with social skills and interpersonal relationships. So while the findings from the first two analyses offer valuable insights into the effects of social context and activity on mood in TBI, notable limitations presented include, first, the lack of a neurotypical control group, which prevented our ability to examine how individuals with TBI differ from non-injured individuals in their time use, patterns of affect, or associations between the two. And second, participants in the present study and the first analysis had reported depression and/or anxiety, meaning findings are not generalizable to individuals with moderate to severe without these symptoms. And that leads us to the present analysis, where we are trying to fill the gaps identified by our previous work in this area. So now I'm going to discuss an ongoing study that we're currently collecting data for, examining time allocation, social participation, and affect using ecological momentary assessment. So here we have the full study design. For this study, our goal is to recruit an uninjured control group, again, to examine how individuals with TBI differ in their time use, patterns of affect, and the associations between the two. However, at this point, we don't have sufficient data to run the comparative analyses, so I'm only going to present some preliminary findings from the TBI group today. Specifically, I'm going to first describe patterns of social and community activity, as well as affective states among individuals with moderate to severe TBI, where anxiety and depression symptoms were not inclusionary. And two, examine the effects of social and community activities on temporal patterns of positive and negative affect in daily life among individuals with moderate to severe TBI. So participants completed first, when they were enrolled in this study, an in-person assessment where they completed paper and pencil versions of paper and pencil tests of cognition and psychological assessments, which included the Ray Vault, Trails test, BSI 18, Colibri, and Satisfaction with Life scale. And then they were enrolled in the EMA platform on their cell phone and completed the EMA period, which was 5 times a day for 20 days. And the EMA assessments included an the same activity assessment that I discussed in the previous two analyses, as well as the PANIS short form that I also discussed in the previous analysis. So for our data analysis for this specific study, we'll report descriptive statistics for the PANIS scores, activity, social, and location context, as well as activity enjoyment and accomplishment. And then again, we use LMMs to examine the effects of contextual variables, so the activity, social, and location context on positive affect, negative affect, accomplishment, and enjoyment. So just a brief background on the participant characteristics. So far, we've enrolled 24 participants have completed the study with TBI. The mean age is about 50 years old. The sample is primarily male, and the time to presentation after injury is about 11 years. And thus far for the study, we have, again, observed favorable EMA engagement with most participants responding to more than 60% of the daily surveys, and the average response rate right now is about 68 to 69%. So here we have the descriptive EMA outcomes, so the descriptive statistics for the positive affect and negative affect subscales of the PANAS. And again, we have some heat plots that demonstrate the average PANAS negative and positive affect scores for each day that demonstrate the within and between person variability of affect throughout the entire EMA period. So again, I just want to point out that each box represents the average affect score throughout all 5 observations each day. So it's an aggregate score. And then these visualizations highlight the participants' affective states and traits throughout the study period. So some participants remain consistent in their affective states, and again, you can see this as the bands remain a certain color throughout the entire study period for some participants. And mostly these participants endorse minimal negative affect and strong positive affect. However, we can also see that on a day-to-day basis, some participants fluctuated in their affective states. And again, we see this by the different colors changing throughout the study period, and we might suspect that this is likely influenced by specific contextual factors. I would also like to note that it is usual for individuals to score generally lower on the negative affect subscale. So these lower scores on the negative affect graph aren't necessarily surprising to see compared to the positive affect chart. So now on the next few slides, I'm going to show the breakdown of the activity, location, and social context across all of the EMA observations throughout the entire EMA period. So our classifications were based on the Part O subscale scores, which I discussed previously in this study, and align with the productivity and social construct. So that's how we decided which activities would be classified as which. So while most time was spent doing other activities, a little over a quarter of observations were classified as productive activities, followed by watching TV and videos, with the least amount of observations spent engaged in social activities. Across all observations, about 79% were spent at home, and across all observations, about 59 to 60% were spent when participants were alone, or were reported to be when participants were alone. So ratings of activity, enjoyment, and accomplishment across all observations were broadly dispersed across the full range of the 1 to 5 Likert scale, and I'm going to discuss the implications of this, which you'll see in the LMM results on the next few slides. So when adjusting for relevant demographic variables, which included age, education, and sex, engagement in productive and social activities and watching TV and videos was associated with increased positive affect. Being at home was associated with decreased positive affect in reference to other locations. Being alone was associated with decreased positive affect in reference to being with other people. No activities were associated with negative affect, but negative affect did decrease over the study period. There was a monotonic relationship between feelings of accomplishment and enjoyment from activities and increased positive activity. So activity, accomplishment, and enjoyment increased as positive affect increased. And there was a monotonic relationship between feelings of activity, enjoyment, and feelings of activity, accomplishment, and enjoyment, and decreases in negative affect. So as activity, accomplishment, and enjoyment decreased, negative affect decreased. So in conclusion, based on the results of all 3 of the analyses that I presented, We found that EMA is a valuable tool for assessing dynamic rehabilitation outcomes in people with moderate to severe TBI. We observed acceptable participant engagement and response rates across all 3 analyses. EMA-derived measures demonstrated significant associations with traditional retrospective self-report measures of participation, and EMA measures of participation and affect captured meaningful between and within person variability across all 3 analyses. We also found that people with moderate to severe TBI spend much of their time at home and alone. And across all 3 studies, participants reported spending a substantial amount of time at home and or alone on a daily basis, which is consistent with existing research. And participants reported spending a meaningful amount of time engaged in productive activities and generally experienced them as enjoyable and felt accomplished when doing them. However, they reported relatively limited time spent socializing. We also found that community activities, social interactions, and location contexts are associated with affective states of individuals with moderate to severe TBI. So we found that productive activities were associated with higher levels of positive affect across all 3 studies. And social activities were mixed. So in analysis number 2, social activities were associated with higher levels of negative affect, but in analysis 3, social activities were associated with higher levels of positive affect. And we should interpret this finding cautiously, as we did not compare these 2 outcomes statistically due to the separate study designs, and the target sample for study 2 included participants who had prior symptoms of depression and or anxiety. We also found that spending time at home and alone was associated with lower levels of positive affect. So how can we use this information moving forward? First, we might consider incorporating EMA into rehabilitation practice. So EMA may enable real-time monitoring of participation, mood, and environmental context in real time, allowing clinicians to identify barriers and tailor interventions to individual experiences and needs. We might also consider prioritizing interventions that increase community participation and social engagement. So increasing the frequency of activities that take place outside of the home and with others could increase enjoyment and positive affect in individuals with emotional distress following TBI. And the emotional cost of such activities should be considered for individuals with pre-existing mental health symptoms. We might also consider leveraging enjoyable and meaningful productive activities as rehabilitation targets for individuals with TBI. And we observed a monotonic relationship between activity enjoyment and accomplishment and increased positive affect across the studies, and building on existing strengths and interests may prompt engagement, motivation, and well-being. And finally, we might consider contextual influences on emotional functioning. So the association between affective states and activity, social, and location context was observed, and these contexts should be considered when developing person-centered treatment plans with the goal of increasing opportunities of positive affect in everyday life. So what are our next steps? First, we definitely want to finish the recruitment of the control group for comparison. So this will help us understand how individuals with TBI differ from non-injured individuals. And our next step after we finish data collection for the current study is hopefully the findings from our current study will inform designing an intervention that we can apply in a randomized control trial to improve participation and reduce negative consequences of TBI, such as homeboundness, sedentary behaviors, and mood disorders. And I would like to thank the support of everyone here, as well as my collaborators and contributors, specifically the Brain Injury Neuropsychology Lab. Most of you are here today, so thank you for being here, as well as a huge thank you to all of our research participants who willingly fill out all of those surveys on their phone for days on end. We really appreciate it. And these are my references. And thank you.